Welcome. The Society for Cardiac Robotic Navigation envisions a society where advanced robotic technologies continuously revolutionize the field of cardiac care, in which the status quo is challenged and improved. With a commitment to innovation and precision, our vision is to empower healthcare professionals with state-of-the-art robotic navigation systems that enhance accuracy, efficiency, and patient outcomes in cardiac interventions. Through collaboration, education, and research, we strive to pave the way for a new era in cardiovascular medicine, where robotic assistance becomes standard practice, enabling safe procedures and improved quality of life for patients worldwide. Healthcare professionals and technology working in synergy with one another. With this in mind, we welcome you to the Masterclass Brugada VT Day. Before we dive into this exciting program, we draw your attention to the following. The SCRN Masterclasses are admission-free recurring events presented by our SCRN board members. Please keep your microphone muted during presentations. Only during discussions and when given the word by our moderators, we ask you to switch on your camera and microphone. Should you wish to share an observation or pose a question, please first virtually raise your hand. Our moderator will mention your name to keep the discussions as orderly as possible. Can you share questions and observations through the chat channels as well, of course? Making screen captures or recordings is prohibited throughout the event. Recordings will be made available next week on the SCRN training video platform. Members have free access to this vast library of training videos. Kindly note that physicians may present products and/or informational products that may not have approval in all geographies. Please consult the indications for use and instruction of all devices used. Today, the Masterclass Brugada VT Day is moderated by two moderators. First, I kindly introduce SCRN's President, Professor Sabine Ernst from the Royal Brompton in London, United Kingdom. Under her leadership, SCRN challenges, commits, and collaborates worldwide to unlock new possibilities in the fight against cardiovascular disease. Professor Ernst is one of the pioneers of remote magnetic navigation. She has established this technique from its initiation to becoming a clinical routine procedure using state-of-the-art equipment, including advanced 3D mapping techniques, and patients with congenital heart disease, complex anatomy, and arrhythmias especially benefit from the technique and form a major part in Professor Ernst's clinical work. Additionally, we welcome in a moderating capacity, Dr. Tamas Szili-Torok, SCRN's Program Director of the Masterclass series since its beginning. With these masterclasses, along with the interactive case discussion series, Dr. Szili-Torok's work within the SCRN promotes awareness among healthcare professionals, patients, and the public about the benefits and potential of robotic navigation systems in cardiac interventions. The SCRN programs under his guidance facilitate collaboration and knowledge sharing among robotic and EP community, and they provide educational resources and professional development opportunities to equip healthcare professionals with the skills and knowledge needed to effectively utilize robotic navigation technologies. Dr. Tamas Szili-Torok, being a strong advocate for improved access to robotic navigation, drives research initiatives aimed at advancing the evidence base for robotic navigation technologies in cardiac interventions, accelerating integration of robotic systems in routine clinical practice. A warm welcome to Professor Ernst and Dr. Szili-Torok. And now, with further ado, I hand over the word to Dr. Szili-Torok to introduce the rest of our faculty. Dr. Szili-Torok.
Thank you very much for this kind introduction, actually. And it is my privilege to introduce the first speaker, actually a friend of mine, and you may not know, but it is very important to recognize that Pedro was among the first physicians who actually dreamed about and desired this society very long time ago, and from the very beginning he is included into these activities. He's a professor and specialist in clinical arrhythmia and interventional cardiology, and the director of a very important heart center in the Daluz Hospital in Lisbon. And of course, we know that under his supervision, arrhythmia treatment became very important and prominent in his whole country, and he has a major role of leading the arrhythmia services. It is also very important to recognize that his center is one of the first ones in terms of numbers and volume, and I do believe also in quality in the world in robotics. They treated already from the beginning more than 4,000 patients with this system, which is actually a very powerful number and shows enormous experience in this. And I hand over the mic to him, and hopefully all of us will be able to enjoy his presentation.
Thank you, Professor Torok. It's a pleasure to be with you in this meeting and to participate in this meeting. My task today is to introduce robotic ablation, but I will do an overview about the clinical evidence and the ablation of Brugada syndrome. Next, please. Brugada syndrome is a genetic disease that was described in 1992 by Joseph and Pedro Brugada. In fact, it's a cardiomyopathy that is related with sudden death, with a special pattern of ECG, and it's an inherited disease. Next, please. When we think about Brugada, we think about a man, 40 years old, that it's in the population in a number that's 3 to 5 in 10,000, and Brugada syndrome accounts for 4% of all sudden deaths, cardiac sudden deaths. Next one. And a description as a genetic disease with a loss of function mutation in cardiac voltage-gated sodium channel CSN5A, but only in less than 1/3 of the cases. And more than 20 genes are related, modifications in 20 genes are related with Brugada syndrome. It's an autosomic dominant pattern, but has a variable expressivity and reduced penetrance. And some risk factors are triggers to sudden cardiac death in Brugada syndrome. Low and high temperature, fever, hormone states, drugs, alcohol consumption, hyperglycemia, heavy meals. So it's a thing that can have a non-permanent evidence of risk. Next, please. The pathophysiology, the exact mechanism of Brugada syndrome is not clear. There are two main hypotheses. The first is repolarization disorder model with the right ventricular epicardial action potential to have a deeper notch when compared with the action potential of the endocardium, so a gradient that can induce ventricular fibrillation and ventricular tachycardia. The other hypothesis is the polarization disorder, where we have a delay of repolarization to slow conduction in the right ventricular outflow. Next. When we think about symptoms, we see that there are no symptoms until two cardiac deaths. And this cardiac death frequently occurs during sleep period due to increase of vagal tone. 80% of Brugada syndromes that have ventricular tachycardia, ventricular fibrillation, had few symptoms before. Some have before syncope episodes. Fever may precipitate the symptoms, and an important number have arrhythmia and atrial fibrillation. 10 to 30% in young people may have these atrial tachycardias. However, 22% of the patients have no symptoms, and 28% will not have a family history of a sudden cardiac death. They appear without previous family history of sudden cardiac death. Next, please. When we want to have the evaluation, we know that it's an ECG. And an ECG that has several different aspects, but usually three patterns. The type 1, that is the real identification of Brugada syndrome, have a curve ST greater than 2 millimeters, accompanied by an inverted T wave type 1 in V1, V2, V3. These leads are the expression in the ECG of the right ventricular outflow tract. Sometimes it's necessary to increase the ECG pattern, and this is possible using drug challenge tests with class 1 antiarrhythmic drugs. The adrenaline tests should be used in people with having a history of Brugada syndrome, have a family of sudden cardiac death history, and symptoms consistent with Brugada syndrome in the setting of questionable ECG abnormalities. Next, please. But there are other entities that can have the same ECG pattern. So we need to exclude acute inferior infarction, hyperkaliemia and acidosis, acute pulmonary embolism, hypokaliemia, and these are phenocopyias of Brugada syndrome. Next, please. And how to treat this entity? ICD is the mainstay of treatment of Brugada syndrome patients. ICD indications are placed when you have a survived cardiac arrest or a patient with a Brugada ECG abnormalities and a faint. Pharmacological treatment may be used with quinidine in patients with symptoms of arrhythmia, and radiofrequency ablation of the anterior part of the right ventricular outflow tract is a new emerging therapy for Brugada syndrome patients, and patients usually that have ICD implanted and are with symptoms of ventricular fibrillation, ventricular tachycardia despite quinidine treatment. Treatment of asymptomatic Brugada syndrome, in my opinion, is unknown. We can do nothing, but we can have problems. The first description of ablation was done by Szeged and described a few cases of ablation of Brugada syndrome and long QT syndrome. It described the treatment as a focal ablation, first application, first activation application in the right ventricular outflow tract for Brugada syndrome and in Purkinje for long QT syndrome, telling that always it have a possibility to start by a premature beat. And if you ablate this trigger, you should ablate Brugada syndrome. Next, please. But some years after, this was in 2003, this in 2009, an experimental ablation in a model of Brugada syndrome showed that it was possible to eliminate the Brugada syndrome pattern and to eliminate ventricular arrhythmias induced during Brugada syndrome evaluation in these models if we do an epicardial ablation. And this was not possible to achieve using an endocardial ablation. Next, please. Knowing that, Nadmani done the first ablations in human in 2011 and showed that the underlying electrophysiological mechanism in Brugada patients was a delayed despolarization of the anterior aspect of the right ventricular outflow tract epicardium. And they state that cardiac catheter ablation results in the normalization of the Brugada ECG pattern, and this normalization induce a non-arrhythmias for the future follow-up without ventricular tachycardia or ventricular fibrillation. And this was not possible to achieve with endocardial mapping. Our experience with the arrhythmia that is ultra high definition mapping, and this was the first one that I know in the world, it was done in a 39-year-old man with the Brugada syndrome and the recurrent arrhythmia storms, more or less 1 amount due to ventricular fibrillation, and was resistant to maximum tolerated doses of quinidine. He had a structural normal heart with normal ECG, normal echo, and normal MRI. The ECG pattern was a Brugada type 1. And during the ablation, we identified that the main substrate, a large substrate, was in the right ventricular outflow tract and a small substrate in the endocardial area of right ventricular outflow tract. We ablate only the epicardium, and we had completely suppressed the ECG pattern. And after 7 years, this patient had no more arrhythmic events. Next one. Our experience is similar to others, and we see a delayed electrograms in the right ventricular outflow. You see here very clear these delayed electrograms, usually in between 200 milliseconds, 300 milliseconds. And if you ablate this area, the pattern of the Brugada syndrome may disappear to a normal pattern, as we show in this presentation that we have done in the Learning Health Institute of Hospital da Luz. Next one. And we also tested the possibility to identify the direction of the activation during the delayed activation using the ripple mapping, and it was possible to suppress in this area the pattern of Brugada syndrome and also to disappear the ripple mapping aspect. Next one. Now I will present some slides that Carl Papone, during a presentation in Arrhythmias 2023, had done in our department, and it was a meeting, a national meeting of Arrhythmias, and was a conference of Carl Papone. He gave us this presentation, so I will share with you. And there are some slides that for me are very interesting. The first one is to decide if the patient has a disease or not, because 11 o'clock a.m. it's a normal ECG, but during night with the vagal influx, it's a class 1, a very severe class 1 pattern. Next one. And when he maps at 11 o'clock, there was a small substrate, but when mapping at 4 o'clock a.m., next please, it's a risk of cardiac arrest. And the statement was, everyone is asymptomatic until at a cardiac arrest if have a type 1, intermittent type 1 Brugada syndrome pattern. Next, please. This is a description of a normal ECG, normal MRI, implantation of an ICD, myocardial biopsy not conclusive, and 8 ICD shocks during the follow-up due to ventricular fibrillation. And you see the baseline ECG and the Amgemalin ECG in a male 20 years old. Next, please. He's doing his normal mapping. He teaches this very well in several meetings, trying to identify the substrate. But without Amgemalin, the substrate was clearly known. No delayed potentials. Next, please. Next, please. After Amgemalin, he could identify a very important substrate, and this substrate has been treated. Next, please. And you see here the disappearance of the pattern of Brugada syndrome during the ablation, and this is very interesting because we can also prove that when you are doing the ablation, the pattern of the ECG is changing and usually shifting for a more normal ECG pattern. Next, please. And it compares the before and after with the Amgemalin, and what happened is that before you had the substrate, after you have no delayed activation and no substrate. Next, please. And with the follow-up, you had before a pattern with type 1, after no type 1 pattern, and Amgemalin. Next. And it demonstrated no news episodes of ventricular tachycardia or ventricular fibrillation during a period of 7 years. Next, please. Recently, in 2024, he have a screen of 755 patients, 265 have meeting criteria to treatment, and he indicated for the patients ICD and ablation. Some patients, 8 patients refused to participate in the register, but 257 participate in the register, and 206 accepted to do ablation. The others were controlled. He identified the epicardial substrate, and he had ablated and have 1 reablation. epicardial ablation. Next one. And what they identified, the risk factors before ablation: have a positive genetic test, have an aborted cardiac arrest, or have a substrate area of more than 9 centimeters square. Next, please. And here is what he presented in Lisbon. And you see here the purple represents abnormal prolonged potentials. Red represents normal potentials. You see the fragmenting potentials before Edgemalin, enlarged after Edgemalin. The areas disappear after ablation, and this means that it was an effective treatment. Next one. Conclusion of this large series is that after ablation, no arrhythmias, and it was completely different from the patients that had done ablation, no ablation, because they have arrhythmias. It's clearly different. So the disappearance of the ECG pattern was a clear success to have no more arrhythmias. Next one. This is a study, the Bravo registry is a study from Nadmani and and a large team of doctors, PP doctors, including Michel Issaguer, that showed that the area of interest for ablation was the right flow outtrack, and after ablation, no more episodes of ventricular tachycardia, only few 7 episodes with more than 20,000 before, and the criteria for success was the disappearance of the ECG pattern. And this disappearance was equally effective in the people with genetic test positive and with people that have no genetic test positive or have no test done. And next, please. And when we see the Shanghai score of risk, to have a spontaneous type 1 ECG means 3.5 points. And if you have more than 5 points in the score, you may have ventricular fibrillation before. In this study, they had only with more than 5, it was possible to have ventricular fibrillation clinically identified. So if we eliminate the spontaneous type 1 ECG, we eliminate these 3.5 points of risk, and maybe this will be clearly important. Next, please. Another score that predicting the arrhythmia event score in Brugada, that if you have a score with more than 10, you have a 95% sensitivity and 89% specificity that you will have an arrhythmia event. Next, please. Where did we come from? We come from 1989 first description, the definition of a genetic disease with the discovery of CCN5A in 1998, and first ablation in 2003, first epicardial ablation in 2011, and large series in 2015, 2017 with type 1. Next, please. What are we now? What say the guidelines? Guidelines say 3 things. First, epi study for asymptomatic patients with type 1 Brugada syndrome is class 2B, not may be done. Implantable loop recorded in the unexplained sync class 2A, that is for me an important question there. Catheter ablation after shocks under quinidine, class 2A indication for ablation. And another important question that, because in the future will not be true, is that catheter ablation is contraindicated if asymptomatic. And there are a lot of people asymptomatic that will have the risk of sudden death. So, next, please. So what will be the future? Ongoing randomized trial to assess effectiveness, safety of ablation in Brugada syndrome, and we have now the BRAVE study. Predicting arrhythmia event scores defining patient indication to ICD or antiarrhythmic drugs with quinidine and clearly to ablation. In the future, ablation, if safe and effective, may be applied to asymptomatic Brugada patients with high arrhythmic event risk score. Thank you for your attention.
Thank you very much for this excellent summary and introduction to the disease. I also draw attention to the fact and the possibility that everybody can ask via the chat function, if you wish, and we try to translate it, or if you want, you can directly ask, of course, if you raise your virtual hand. Any questions from the board or the audience? Maybe I missed it, but can you actually summarize your personal experience? How many patients you did so far, and what is the? I see that there is already a very long follow-up, which is very convincing in that particular patient. But maybe if you give some more broad perspective about the follow-up of these patients in your experience.
I have to tell you that until now, we are very strict to do this ablation. We do ablations in patients guided by, according to the guidelines. And the guidelines tell us ICD and quinidine refractory to quinidine. So they are not a lot. But all the patients that we have done, and there were more than, I will tell you that were more than 5, less than 10, but it means all of them, except one that has a unique episode of ventricular tachycardia. All of them have no more episodes of tachycardia and are not with antiarrhythmics. So it's a clear differentiation between what we have done before and what indicated the ablation and the modification. I think that all the data from BRAVE study, from the study of Papone, from our own experience, are completely confident that we do a strong modification of the substrate. Where we need to go, and I think that we need to go to identify what are the patients that are completely unknown, but have a high risk for sudden death. And those patients, young patients, should be treated if we are safe to do the approach and if we do an easy ablation, because it's not very difficult to do it as ablation. The approach is always risky because it's not 100% safe. But the treatment in itself, it's a fantastic treatment and have a clear evidence that you can change this G pattern. So, and disappearance of the delay potentials, it's always interesting to do. The only thing that I don't like is that is an epicardial approach. And for me, even if we have no risk in the epicardial approach, is not always possible to a patient that is risk zero.
Thank you. I think Sabine has a question.
Yeah, I was thinking exactly in that terms. You showed that the initial ablation attempt was endocardial, and there are other centers that reported their experience. How necessary is it to be epicardial as opposed to endocardial? Do you think it's doable from the endocardium, or is it just you don't reach as far in? Can we tell from the thickness of, let's say, a CT scan or something, if we could do it endocardially?
A fantastic question, because the problem is to be or not to be transmural. Because you can go from the endocardium and attain the epicardium. It depends on the energy that you are using. So we have some new energies we don't know yet. The patient that I studied and I published was because I think that the disease is not equal for everyone. The way we map is not the same for everyone. So if you have a better way to map, maybe you can see from the endocardium some aspects that you are not seeing if you are blind. We are not burned by the endocardium, we are burned by the epicardium, we have not done more. But it's true that sometimes we can have, for the outflow-tract ablations, we have difficulties to burn, but usually burn endocardially. And a lot of times the premature beats come not from the endocardium, they come from the epicardium. You have a delay from the activation. So I think that is a fantastic question, and it will be fantastic if we have a good answer telling that is very easy. You can go endocardially and map the area, and the anatomical area will be done. So I think that the answer is we don't know what we can do in the near future, but we know that the treatment may be very, very useful.
Thank you,
I think
Professor Adragão. We should move on. So, Sabine?
yeah, that's my pleasure. Thank you very much. And we have more time for discussion after David Burkhardt's presentation. So let me just introduce him. I said, Dave is, of course, the robotic epicardial VT man in the world, probably the person with the largest experience for VT ablation of all substrates with a magnetic navigation system. I think that's fair to say. I'm sure I'm not exaggerating that. And I think that he's exclusively using the robotic system for this kind of arrhythmias. And of course, it's not a surprise to say that he also has a very large Brugada experience. And I'm very happy and honored that he shares his experience, a case presentation, really, live in the box with us, and allows us then afterwards to ask him really technical questions. So for someone who's considering doing the same approach or offering that to your own patients, this is the moment to ask all of the questions. So listen very carefully, and I hope that Dave is sharing all of his experience and tricks and tips with us. Thank you.
Well, thanks very much. I appreciate the introduction. Good morning from Texas. So I'm going to share one of the cases that we've done. I've done probably 9 cases of Brugada, and I'm told that's the largest volume in the United States. So not incredibly frequent, but we do see it. As has been described, won't go through this too much, but genetic abnormality. So, in the beginning, I was very surprised about this. How would a channelopathy potentially present as a disorder, showing that you would have electrical abnormalities, typically seen in something like right ventricular dysplasia or something else. So I was very surprised when this came out, but very interested to be involved. And you've seen these things. United States, we don't have osmoly, so you can use flecainide, procainamide, the most common drugs that we use here. But in my case, I'll show you the one thing that we actually did is you can use refrigerated saline. And so that's what we put actually directly into the epicardium at the time. And since these are temperature sensitive proteins, you get a significant response to that, and can be very interesting. And of course, the EKG abnormalities, and then as in the previous papers, you see the electrical abnormalities. The first time that I went epicardial looking at these signals, I actually thought there was noise in our system. They were so remarkable. And, not the typical ARVD in that they're scarring and then you see late fractionated potentials. It was a continuous electrical signal in an area that was, greater than 2.5 millivolts. And I was astounded at what it looked like in that my initial case. And here you see, a couple of examples of those. So I'll go to one of the cases referred to me, a 23-year-old male, genetically and phenotypically positive for Brugada syndrome, who was on quinidine. He was referred for an ablation after he had a storm after a febrile illness. And so here's the Odyssey portion of the case, which I'm going to show, and then I'll go back to the slides to show you kind of the specifics, since it's a little difficult to see in the video. But the first thing here is the epicardial access. And, kind of in response into one of the questions before, in this patient and in others, the endocardium for me was entirely normal. And I don't think that you could say anything from the endocardial map on any of these patients. epicardium, however, was remarkably abnormal. The voltage, not necessarily. There is some heterogeneity in voltage changes, but the signals with those just continuous delayed electrical potentials were very remarkable. So here's the epicardial access portion of the procedure. Like I said, for me, the most important portion of this, and I personally would not, true Brugada, I would not address endocardially. I think epicardial is very, very important on these, both in seeing the particular signals, as well as I think it's much easier to address these. And then I'll say, and I'll move this forward a little bit, but I'll say that these patients have done very well. Of the 9 patients, none of them have had recurrence. They have just done really remarkably well. The other thing that I'll say is that in my entire epicardial experience, not just in Brugada, magnetic navigation is fantastic. And that'll show you some of the navigation in here as I'm creating the map. But you just move the vector and the catheter tends to move over to fill it up. And in this case, with Brugada, what I like to do is, even though the puncture was anterior that you kind of saw with that, eventually I move the sheath posterior using the wire, come back around over top, and then you see me navigating from a top-down version of this. And so in doing this, I'm doing a couple of things. I'm taking the voltage. Anytime that I see an abnormal signal, I'm marking that. And then we're also doing, in a separate screen, you can't see it here, but we're doing late activation timing. And so all of these are points, even though they're substrate, they're also activation time. And I'm taking the last signal that is connected to anything under the QRS. So anything, if there's a isoelectric point in between, I call that a delayed signal, and I'll just mark that with a dot. But otherwise, if it's connected to anything under the QRS, then I'm timing the latest activation on these. And these very typically will be in the right ventricular outflow tract. And I do the entire ventricle here. I think it's very important to get really the complete substrate of this, because we've seen some overlap in what looks like ARVD and Brugada, even though genetically and phenotypically it's Brugada. And so, in addition to the Brugada type of signals, we'll also ablate anything that appears to be abnormal and, true epicardial scarring, not just the low voltage due to epicardial fat. And so here you just see me completing the map as we go through, and then I'll skip forward some. And you see just how easy it is to navigate with the robotic system. Manually, you've got a couple of options, and that is you would have to use a deflectable sheath. I think that can be helpful. And then the other is you have to do large loops with manual catheters to really get around. But the disadvantage to manual, in addition to the difficulty in navigation, is that with magnetic navigation, when I'm ready to burn, I put the vector, facing towards the center of the heart. And so that is really the optimal contact force and directionality to deliver the ablation lesions. And so that I think is a significant advantage with epicardial ablation using a remote navigation. And then here you see me marking these things, and then eventually I'll move forward, and you see kind of the ablation lesions coming in, and then there. And so the very typical kind of outflow tractish ablation on this. And then I will going to go back to my slides. And so here you see the baseline EKG with, a hint of the ST segment changes in this patient. And then here, just to show you another, it's a different patient, but just to show you the epicardial access. And so I use just the standard 2E needle. You see the tenting of the pericardium here. You see the puncture through it. And then after that, you advance the wire. And the key to this is you want to make sure that the wire encompasses more than one chamber. And so that's really what I do here. And that's so I make sure that it goes all the way around the pericardium. That does a couple of things. If there's any minor adhesions, it breaks those up, but really confirms you're in the right space. So you also use intracardiac echo to make sure that that the wire doesn't traverse through and through in the right ventricle, and to confirm that you're again in the right spot. I tend to use a stainless steel sheath. I think that for me, that's very nice and helpful, particularly in larger patients of where you go through a lot of soft tissue. That navigation becomes difficult because the torque transmitted goes into the soft tissue as into the pericardium. And then you see, some of the robotic navigation and that moving the catheter back and forth just with the vector is very easy. And then, there's an example of, kind of that movement with the magnetic system makes that very easy. With a manual, what happens in this exact same case is that if you advance the catheter manually, that the tip of the catheter would actually slide to the right. And so you would have to put more curve on your catheter to try to get to the same location, but it tends to, advancing with manual just tends to move you out of the right location. And so here, going back to the patient, you see their baseline EKG in the lab. And then what we did, and this is after epicardial access, is that we put cold saline into the epicardium. And you see these dramatic changes here throughout. And so those are very interesting. I don't necessarily use procainamide or flecainide or anything like that before mapping, because what I've found is that these signals are present all the time, and you can definitely see them, and the signals themselves I haven't necessarily found to be more dramatic when doing that. You do see some changes in the timing and position of the signals, but they seem to be there all the time. And then again, another example of the EKG post-cold saline. And then here again, the different case, but another Brugada. And that you see, some of the differences here that, in this voltage map, really there's not much, low voltage areas. I don't know if you can, it's a very small screen. I'll show you a better one, but you can see these signals down there on the Bruch's system are just very impressive. And you see that in this area of ablation is not necessarily that large of an area and doesn't necessarily have to be. And then just another video of that. And here's kind of a blow up of some of the signals that you'll see. I mean, these very interesting signals, not necessarily even the most dramatic I've seen, but you see these type of signals, and those are really the ones that we're targeting. Here, a different example, and you see some of the different heterogeneity that we see in this, and that in this case, there's actually more scarring, possibly due to a larger, more obese patient, epicardial fat. But we've seen some more true scarring that does appear to be more consistent with the ARVD type of scarring that we see in some patients. And like I said, we do tend to address those in addition if seen. Here, another one, more significant scarring that we saw. And again, a larger, more extensive ablation lesion than we would typically do for compared to the previous patient, which was a relatively small area. And then this is our patient again. And so this is post-ablation. Once again, injected refrigerated saline into the epicardium. And you see really no change from the baseline in this. And so that's, a confirmatory that we're done. In some of the cases before this, we did not actually do any confirmation post-ablation with procainamide. Procainamide is what we would typically use. But again, just ablating the signals, those patients did very well. This patient in follow-up of 5 years did find no further events, nothing on their ICD. And all the other patients that we've done have also been very similar, nothing further. And so at this point, I'm happy to take any questions.
Thank you, David. That was really very instructive and very, very hands-on. We have a number of questions from the audience. And let me ask maybe the first question, and that is, how much saline are you injecting? 50 cc's or more?
Yeah, I'm usually putting like 200 in
200.
Relatively quickly, yes. And then we drain it out before we do the mapping and ablation. But but put it in very quickly, try to make sure that the sheath, the tip of the stainless steel sheath is in the anterior location when we do it. And then put that in very quickly. And then, you see the changes, we record the changes, and then we just drain it and then go to the mapping and ablation.
Okay, so you don't leave it in during the mapping, and the effect lasts for 20 minutes, 30 minutes?
Actually, yeah, it lasts a while, and so 20 to 30 minutes is fairly typical.
And the only reason to take it out would be for the hemodynamic consequence of the fluid being in the epicardial space, or you could just leave it there, right?
No, I think it's the same reason when I'm mapping epicardially, I don't even hook up the catheter to a flush, and it's like I want it as dry as possible. I think that keeps me in better contact with the epicardium, and so you're less likely to get non-contact low voltage. So I think I get a better voltage map from that. And then the same thing with ablation. When I'm doing ablation, I don't want fluid building up in the epicardium. I want as good contact as possible. So we're constantly pulling back saline even during the ablation.
Okay, so that was a question from Pete Weiss, I think, what your irrigation settings and the power settings are for the ablation itself.
Yeah, so during mapping, no irrigation. During ablation, typically 40 watts, and with this catheter would be 30 cc's.
Okay, and then take it out as quickly as it goes.
Exactly. So someone's draining the side port as we're ablating.
Okay. I see Tamas and Pedro are here as well. So shoot more questions. There is a number of questions from Jack. Jack, do you want to ask a question yourself, or?
Yeah, I can do. I'm in a shared office, so apologies if it's see. Given the high rate of atrial fibrillation in the Brugada cohorts, actually the gene one, is there a role for prophylactic? I'm sorry, for prophylactic ablation in these cohorts, or would you just wait? Or if having an ICD, you'd probably see AF, right, in your regular monitoring.
You broke up. I think the question was about prophylactic ablation. Is that correct?
Mm-hmm.
Okay, so we have actually had a study for quite a while since this came out of if they're genetically positive, proceeding with mapping and ablation to see how they do. Of course, it's in the United States, at least, the number of genetically positive Brugadas that you just happen to find is not very much. And so we've got less than, I think in the entire US, I think we have less than 10 people enrolled in the study, which has been enrolling for almost 10 years, I think. And so we can't say anything scientifically enough about it. But I do agree with others in that I think if you see that, it's reasonable to consider mapping and ablation. But scientifically, I don't think we can say that yet.
Of course, yeah, that's really helpful. And the second question was, do you think there could be a role for ECG imaging, perhaps, if you do arginine testing here in Europe or your equivalent pre-procedurally, and you could perhaps plan your zone of interest before going in?
Personally, I've not found anything, EKG imaging, MRI imaging, any sort of pre-planning imaging to be as useful as really going in and just the epicardial mapping itself. I think that that is the for me the be all and end all of it. And so if we saw that in sort of questionable patients, potentially if that an EKG imaging type of thing showed really no abnormality, maybe that would be beneficial. But for me, nothing has been nearly as close to as useful as physically looking at the signals on the epicardial surface.
Yes, it's true. I think that epicardial approach is absolutely necessary now because you have no measure of what means type 1 pattern very expressive. But it's surely possible that with a specialized ECG measurement, we may identify the area of risk. And this area of a risk will define what we need to do in a symptomatic patient. So I think that a concept that it's very important to analyze for near future is the dimension of the substrate and that before being there. And maybe there we can identify asymptomatic patients that may have results during ablation because it's not necessary to do everyone. It's necessary to do to those that will have ventricular arrhythmias and ventricular storms. And we should identify them before only in score characteristics. And I think that also it will be possible with the analysis of the ECG, with the artificial intelligence. Now it's possible to identify only by the P wave the possibility to have a diagnosis of Brugada syndrome. So nearby we will say more and we'll know more about what we will do. It's for that I don't think that it's necessary to say what is contraindicated. If we think that in the future will be indicated, we should be that until now we don't know. And when we don't know, we don't do. But we are expecting to know for doing and doing well.
It's an exciting time to be joining the EP workforce, definitely. Thank you very much.
Carlos, with the question?
Yeah, I have a couple of more kind of practical ones. Dave and Pedro, how is this procedure done? Is it under general anesthetic? Is the patient awake? Is it important how alert the patient is at all, or is that doesn't matter at all? So is GA a standard for this, or?
Yeah, for me, I use general, and
yes,
they don't have to be awake at all.
We do the same. It's important because if patient has a storm or a thing like that, we should have, and it's stable to do the mapping. I think that the Desmalin test or the cold saline, it's important because the dimension of the area increase of the pattern. So if you have a small pattern of ECG, they decrease, and it's for that when you treat, the pattern disappear. So if the pattern may increase, it's because you have a larger substrate. If the pattern decrease, it's because you have a smaller substrate. If it disappear, it's because at that time we have no delay with activation. So I think that this is the way to have an epi study of the area.
Yeah, that would be interesting with non-invasive mapping to see what the effect is, how large something would change. Again, from a practical standpoint, I think Pedro showed this paper from the Bordeaux group where they showed the LAD coming down and showing more right ventricular substrate, but also left ventricular substrate. How important is it to know where the coronaries are? Is that something to know, or is it something that is not necessary?
For me personally, I've this is something I'm asked in, everything. And so we have never, for more than 20 years now, we've not shot nor cared where the coronaries are with the epicardial ablation. And we've not had any complications related to that. From other centers that we have heard, there have actually been more complications from shooting the coronaries, particularly in young hormonal females, than the complications of ablation in this case.
Hey Dave, this is Pete Weiss. So I'd love you to just expound on that just for a moment. This is true not just of Brugada, of course, but all epicardial cases that you're doing. Is that correct?
Yes, that's correct.
Yeah. Okay. I just want to really clarify that for folks because it is a bit of a departure of what we're taught, but I think important.
Yeah,
Yes,
I think that's also,
the biggest issue in the epicardium is the phrenic nerve.
Exactly.
And that that's the thing that you worry about. PFA may be a potential benefit in that location. In fact, one of my partners this week was attempting to isolate an appendage in someone that had a Watchman in, and was unable to do it endocardially. And luckily, the patient had a pericardial effusion going into the procedure. And so he actually put one of the PFA systems epicardially directly over the isolated epicardially in the tip of the appendage, as you know, is right over the left phrenic, and so with no issues. So in this case, PFA could be a game changer for what we're doing in the epicardium.
Then you'd really need to watch the coronary arteries for spasm too. Yeah.
Yeah,
we have experience
well,
with-
that's interesting. He's very close to the circumflex in that location too, but
Oh.
didn't see anything.
We have experience with the PFA, focal lift PFA in the epicardium for ventricular ablation. And in fact, if you use nitrates and if you do ablation, no modifications and nerves were not a problem. So I think the problem is to know if the lesions are there after hours, because
Yes.
the retractable aspect of the lesions for the ventricle will be somewhat different from the atrium. The thickness of the wall may be a different way. And if we remember the experience with fulguration before, we understand why some patients have very good result acutely, and 2 days after, 1 day after, have again symptoms and have arrhythmias. So it's a wonderful wall, but we don't know the limits, neither the efficacy. I think that for the atrium, there are a lot of results, and the results are very good. But for the ventricle, results are interesting, but I don't know if they will be similar. But for these aspects, for epicardial, it's a fantastic way to do. Suppression is immediately. It's incredible. You apply and they disappear.
Thanks, Pedro. There is one more. Maybe we have a little time for one more question from Pekka, who raised his hands a while ago.
Yeah, all right. Do you hear me?
Yes.
Yeah. Unfortunately, I don't have the camera here. It is work computer. Thanks, David. Excellent presentation. It's really nice. I have a question about the epicardial ablation in general, not only for the Brugada patient. Do you have any weight limits there? Because that's the problem usually when we have the dilated cardiomyopathy patients, ARVT patients, if they are fat. There's so much fat in the pericardial space also. Sometimes you have lots of low voltage areas there, but I'm not sure that can I always see the fragmented signals there. What is your feeling that do you go even the fat patients that epicardial, or do you have any weight limits or anything like that, or any advice for us? How should we do these?
Sure. So I don't think I have a particular weight limit other than, of course, the table limit. And for me, it's actually less of an issue of weight than it is, what is the aspect of their belly to their sternum. And that's so if they have there's some very large people that their sternum relative to their belly is relatively flat. And so their weight hangs down lower and more towards their groin, and epicardial access in them is relatively easy. The ones that are difficult, the two that I worry about are ones who have a very protuberant, rounded belly just above their sternum. And the reason for that is if you can't, when I'm getting access, if the belly's protuberant, I actually try to push it down, because I mean the stomach, the colon, everything is pushed up in your way in that case, and you of course want to try to avoid those. But if that is unable to be compressed, then the problem is the heart may be very close to the sternum itself, and your angles getting into the pericardium are awful, and it may be nearly impossible to navigate in those cases. The second one that I worry about is, and you see this more in ARVD, certainly in others, but someone whose liver passes past the midline and occasionally even all the way over to the left. And that, do we go through the liver all the time? Absolutely. We've seen this on cadaver studies and things like that. But if you can avoid it, you'd certainly like to avoid it. How do you know you're in the liver, by the way? When you're in and before you hit the pericardial surface, you put in a contrast and it quickly dissipates. That's liver. That's pretty much all you see. Do we go through it all the time? Yes. The two major complications associated with epicardial access that are deadly that have been reported in other series and we've seen before. So one happened here, and it was not during epicardial access for ablation. It was actually during a hemorrhagic pericardial effusion, and that they drained the effusion, but they did lacerated a liver artery going in. And so that was a significant complication. It was a late recognition of what the problem was. It thought it was still associated with the hemorrhagic pericardial effusion, even though it wasn't. That was a patient who ended up going to interventional radiology trying to stop it, but it was too late in that case. The other is a perforation of the thoracic vessels, if you're very anterior towards the sternum, that is certainly a risk. The problem with that is you don't necessarily recognize that until you pull the sheath out. So you may have sheath through the thoracic artery, thoracic vein, but it's effectively tamponaded with the sheath in. But then after the case is over, you're like, well, pericardium's dry, I'm going to pull the sheath out, and then there's a rapid decompensation, and that is typically, we haven't seen that here, luckily, but that is what has been reported in other series. And so, from the weight standpoint, if I am very worried about the liver or I'm very worried about the angulation, in those cases, I will actually ask a surgeon to get the access for me. And so they'll do a cut down and physically depress the liver and everything else getting in. And for me, that's been, in those rare cases, it's for me the safest way.
So, just a quick yes or no. Have you done parasternal access for the epicardium?
No.
It seems to be extremely rare, and I haven't done it either. So.
We had done a case with a complication during ablation. The patient had been submitted to surgery. Next day had a store, and we opened directly and ablate directly. It was fantastic. Nevertheless, he has a mediastinitis after, but he's alive. It's without any arrhythmia after that, and it was a fantastic treatment during a very difficult situation. But sometimes we need to adaptate our treatments to the needs of the patient, and this is not always written, but it's possible to do. And since the time that we worked with Mel, we had experience to do ablations even without open arms, without thoracic open thorax, without open arm. during scars that we do CVG with treatments of ventricular tachycardia. And this was very important for today. The other thing is that sometimes we had necessary to evaluate not only the bipolar measurement, but also the unipolar measurement to identify what is a really scar or not. And this for epicardium is also important.
And I will say that we have significant experience with open chest ablation, and not related to Brugada ever, but in patients who've had previous cardiac surgery or who are undergoing concomitant surgery for another reason. Open chest ablation is fantastic. They can do great 100 minus 100 cryo lesions that are very deep, and so that's another thing to consider in particular situations.
Is that?
Thank you so much for that very interesting discussion. The Society for Cardiac Robotic Navigation organizes masterclasses aimed at providing in-depth educational opportunities like this for healthcare professionals interested in advancing their knowledge and skills in the field of cardiac robotic navigation. Additionally, SCRN cooperates with ERA, HRS, and APHRS in joint sessions. The next joint session scheduled is the one at ERA 2024 in Berlin, early next month. So in case you are traveling to ERA, please mark your calendar for the 7th of April at 8:30 in room 7, and SCRN will hold there a very interesting session moderated by Dr. Jan Janusek from Moto University Prague and Dr. Tamas Szili-Torok from Szeged, Hungary. Dr. Laura Vitali Serdos from Fürth, Professor Sabine Ernst here from London, Dr. Annemarie Noten from Amsterdam, and Dr. David Burkhardt from Austin will have some great information to share with you. We would love to welcome you there. In case you are not traveling to Berlin, we hope to welcome you at our next online event, which is the interactive case discussion held on the 20th of April at 1800 CET. Professor Lukas Somowski from Warsaw, Poland, and Dr. Michael Zawane from Phoenix, USA, will moderate this free online session. Dr. Krzysztof Dubowski from Warsaw will present a very interesting robotic congenital case and explain why the use of robotics is particularly useful in congenital patients. The second presentation is in the expert hands of Dr. Pranithka Tripathi, who presents on subaortic LVOT, the anatomical gateway to the LV summit. We are very much looking forward to your attendance there. Registrations are already open and can be made through the SCRN website, www.scrnglobal.com. If you become an SCRN member for only €70 for 2 years, you get access to the training video platform. And of course, you support SCRN educational efforts throughout the year. We value your support very much. It is now time to close this first masterclass of 2024. I kindly would like to take the opportunity to thank our full faculty, Professor Pedro Adragão from Lisbon. Thank you for your excellent presentation. Dr. David Burkhardt being here with us very early in the day to share enlightening life case insights, and Professor Ernst and Dr. Szili-Torok for moderating this event. And of course, a warm thank you to the SCRN board working behind the screens to support these events, and to you, our audience, sharing your time, effort, and enthusiasm. Thank you so much, and see you soon.